Hi. Hi, good morning, everyone, or afternoon, evening, depending on the time zone you're in. I'm Dr. Manny Mangat, and I am Clinical Director at IVF Australia of our Sydney CBD service. I also work out of our Greenwich and Alexandria facility. I am a fertility specialist, gynecologist, reproductive endocrinologist, and so I look after women from adolescence right through to fertility preservation, preconception, IVF treatment, fertility journeys, followed on by gynecology, and finally menopause if needed. So today, the topic I have been given to talk about is fertility preservation. It is a very current, up-to-date topic, and there is a lot of media surrounding this. I'm just going to try and advance my slide. Perfect. So this here is just putting up a few recent articles that touches on the media coverage that has been getting worldwide interest. And large companies like Apple and Facebook have made recent announcements that they will offer egg freezing for their female staff members as a perk. And they are even offering to pay for the egg freezing of their clients. And, you know, as it is expensive and in some countries not covered by Medicare if it is done for social reasons. So today we're going to talk in general about fertility preservation, egg freezing, what's involved, why you might consider it, the technology behind it, and how it has become a real option these days. It is no more an experimental process. It is now a very valid option with very good success rates, and it's definitely working very successfully. I see babies born from frozen eggs on a weekly basis. So all of that is amazing. Now, we can see here, this slide is just meant to show how society has changed over time. And the average age of first-time mother in Australia has reached almost 31 years of age. When our mums were having us, most of them had their children in their 20s. However, these days we are all delaying our childbearing, and that may be for many different reasons, which I'll go into in a moment. And in addition, the number of births to women who are in their 40s has also continued to rise. So the average age of patient that we see these days, or that I see in my practice, is late 30s, actually. 38 or 39 years of age is the average age of patient I see. And, having technology available these days to freeze eggs, I think, is emancipating and empowering, and actually giving women the choice of having their families later successfully and safely. So this here shows, again, the trend of increasing age, and it's a worldwide problem. All over the world, women are delaying childbearing because in reality, we may all want to complete our education first. We may want to, be more financially stable. We may actually want to achieve equality in the workplace, and why not? We may actually want to find Mr. Okay. There is no Mr. Perfect, I suppose. And in the old days, when there was no COVID, we might have actually wanted to travel and do a few things before we were tied down with children. However, these days, we're not traveling as much and therefore maybe have more time, but there's a multitude of reasons as to why a woman may decide to freeze her eggs. And I know in our previous talk with our discussion on the couch surrounding nutrition and fertility that, we shouldn't focus on age too much because it's depressing and we can't change it. But we can't ignore that my profession especially makes me acutely aware as to how age impacts a woman's fertility, primarily by affecting egg quality. So with regards to this, I think when we start to look at egg freezing, we freeze that egg in time, and we freeze it at the quality of the age we froze that egg. And it behaves that way, in that fashion of it being most intact when we then use it in the future. So, it's an amazing technology available to us now. And in reality, it is going to give us the biggest chance in the safest, quickest possible way to conceive later in life if we have had the opportunity to freeze younger eggs. My next slide is basically just showing us a graph. Now, this graph is quite alarming. So women are born with all the eggs they'll ever have. Now, all our egg cells live in little primordial follicles that are called primordial egg cells. And these exist in our ovaries while we are forming in our mother's tummy or uterus. So the highest number of eggs we're ever going to have is actually when we're about 6 months gestation in our mother's womb. And we are then genetically programmed to lose these eggs rapidly over our lifetime from birth. And the initial rate of recruitment each month out of these primordial dormant cells into the preantral phase is genetic programming. We have about 100 egg cells that come out of resting. And until puberty, there is no signal coming from your pituitary to tell the ovaries what to do. So every month, those cells that have come out of resting, it's almost like a one-way ticket, where the cells would then just die off, and the following month it all starts again. Now, what changes at puberty is that once we go through puberty, our pituitary matures to send FSH signals to those preantral follicles. Those preantral follicles in our ovaries release a hormone called AMH. And most of you would have heard the term AMH because that is a blood test that can be done to measure your egg reserve. So it doesn't tell you how many eggs you have, but it tells you a hormone level, which can be plotted on a graph based on age to tell you if you have normal, low, or high hormone levels for your age. Now, important to note that the level is purely a marker of quantity and not a reflection of quality. Now, egg quality has other determinants like environmental factors, general health, medications you may be taking, and as I said, largest determinant that we can't change, unfortunately, is our aging. So once you go through puberty, your FSH signals then will on-recruit an antral follicle group of follicles, and usually that's age-dependent and AMH-dependent. So when you're young, you have about 15 to 20 recruited in a cycle, and then the hormones manipulate those follicles, and one of them will win the race to be released or to ovulate, and that's the chance, that's the egg you're trying to catch when you're trying to conceive. And the chances of conception then, besides relying on a good egg, normal sperm, functioning tubes, functioning anatomy, is also the quality of that egg. So if we were to look at a slice through our ovaries, this is what I'm showing you in these 3 photos. It's quite alarming to see. So at birth, which is the first image on the left, you see all those little circles, and they are the primordial cells that house the eggs. And you can see that there's so many of them, they're crowding the stroma in the ovaries, and those cells are important for their cellular makeup to nourish the eggs that are within them. Now, you can see in the next picture that by 25 years of age, you can already see that the number of those follicles or little primordial cells have decreased in number. And at 50, which is where we're then winding down and getting ready for menopause, you can see there's the odd egg-containing follicle left. And once we run out of eggs, we then stop menstruating and we go through menopause. Now, we haven't found a way to make egg cells out of any other cells in the body. There's been a lot of research around stem cells and regenerating other cells in your body into egg or sperm cells. But all of that research is currently done in mice and animal studies. And, we haven't taken it to clinical utility at this point. However, clearly that may be something that changes in the future. But at this point, we are still racing the biological clock, and we are still dependent on the eggs that we have been given, and we still haven't found a way to change the aging that occurs in our eggs. And therefore, what we can change is to preserve those eggs early so that we give ourselves the best chance of procreation later on. Now, just to show you, and this video here, you can see there are two videos running concurrently, and the animation is looking at what you see of fertilized egg and sperm in embryoscopes. So you can see that the egg fertilizes, and there's two little circles called the pronuclei, and then they start dividing through 5 days of development into a blastocyst. And you can see that this is a comparison of a young egg on the left creating an embryo and an older egg on the right that is creating an embryo. So we can see there that on the left, the cells are dividing beautifully and regularly from, 2 pronuclei to then mixing the chromosomes that come from the egg and sperm. There's then a process of recombination, doubling and halving to make a new person, because we're not trying to make a clone of ourselves. We actually have to recombine all the chromosomal material to then make a new person. So that embryo has a lot of work to do in those 5 days of growth before it implants and starts the journey of becoming a baby. And initially, it is the egg that is the boss of taking in the sperm nuclear material, and the spindle in the egg is what controls all this chromosomal division and multiplication. And you can see the embryo on the left has beautifully gone through the motions, and it's now compacting to become a tight ball of cells. And this never ceases to amaze me. It's now forming a cavity, and those cells are now dividing into what's going to become the baby and what's going to become the placenta. So the lump of cells on the right that's now moving down to the 5 o'clock mark is what's going to become the baby, and the ring around the outside is what's going to become a placenta. So that's a beautiful double A-grade blastocyst on the left. And that is what we would expect young eggs to do. However, as you can see, the embryo on the right went through a few divisions and didn't quite do the right thing and didn't end up looking anything like the one on the left. And that's the one, if we had transferred, probably would not have ended in implantation or might have ended in an abnormal conception. Now, as a woman gets older, why is it harder to fall pregnant? The reason it's harder to fall pregnant is, regardless of obstetric complications, our uterus usually doesn't tire. That's why you see lots of things in the news or on, in magazines that women fall pregnant at 50 years of age, and that's usually from the help of an egg donor or from eggs that have been frozen at an earlier age. So our uterus continues to function, and our endometrium functions. So if we're generally healthy and generally able to minimize our obstetric complications, we're generally able to carry a baby till later on in life. However, the spindle in the egg, as I explained before, is the apparatus that ages. Because of nature and the way our body ages, because of cellular metabolism and reactive oxidative cells that are released, that happen as normal byproduct of our metabolism and our cellular repair, and it's certain of these things that you can't control. You can obviously put yourself in the best health to help slow down the process. You can take antioxidants that help mop up reactive oxidative stress. You can take supplements that help nourish the eggs you've got, but the background cellular metabolism and aging still progresses. And that's why we know that, our biological clock doesn't match our appearance. So even though we feel healthy, we look young, we might be in our 40s but look like we're in our 20s, our eggs unfortunately still progress along their pathway of aging as they have been programmed to do. So this slide here is just to say that even if we have a younger partner with great sperm, it still gets harder to make a normal embryo, as the spindle apparatus is the boss in the egg that controls the making of these chromosomes. However, it is important to note that obviously the better quality the sperm, maybe less, there will be less work involved than for the egg. So we might still make better embryos. Now, as I mentioned before, not forgetting lifestyle. So a lot of my patients are so concerned. They're like, oh, I'm going to come and freeze my eggs. Is there anything special I need to do in preparation? They are so worried about the Friday night drinks they had or the few additional coffees they had because they've had a stressful time at work. But what I always say is keep it in perspective. We just said in our lifestyle talk previously in our first session on the couch that don't remove every single food group. It's important to keep things in perspective, but it's important to put yourself in the best health possible. And if that involves reducing your alcohol to maybe only 1 or 2 standard drinks a week, reducing your caffeine to 1 single shot a day, making sure that you're getting nutrients through your diet, and if you're not, maybe taking the appropriate supplements and folic acid, definitely not smoking, so just doing things that are sensible, making sure you reduce the chemicals in your environment, making sure that you don't heat your food out of plastics, making sure that you use glass, to package your food, or stainless steel for your water bottles. Just simple things that you can do to help your overall lifestyle. Definitely, helps to have you prepared, whether that's for egg freezing or to have a baby. However, your stress at work, for example, is going to affect your diet and it's going to affect your sleep, and they may affect things in the long term, but it's not directly going to affect your egg quality. Now, a lot of my patients also ask about complementary therapies. And I, for one, consider myself a holistic practitioner. I really think that our general health, our nutrients from our diet, our preconception preparation for pregnancy or an IVF cycle puts us on the front foot, puts us in the right frame of mind and the right state of health to deal with the hormones we're going to take, or to deal with the IVF cycle we're going to go through, or to deal with just coping better with the stresses of life. And we know that a lot of good nutrition and a lot of supplements don't actually do any harm. So therefore, however, it is important that you need to know what to take, how to take it, how much to take it, and when to take it. And that is why it's important to speak to a dietitian or your nutritionist or your fertility specialist. Now, you may get conflicting advice around complementary therapies. And the reason for that is because there aren't many good quality, large randomized controlled trials that are giving black and white evidence. So therefore, a lot of studies that are emerging have to be interpreted carefully and have to be looked at from several aspects by someone who is experienced in the field to then guide you down the appropriate pathway. So please don't just do a little bit of Dr. Googling and then put a plan together for yourself, because that normally, is what we don't recommend. Now, some medical conditions can also impact your fertility. For example, endometriosis in the ovaries can affect egg quality. But, and some medical conditions may cause you to consider fertility preservation, meaning you may be looking at starting a particular medication that may affect your egg quality. You may be looking at starting an immune modulator for arthritis, for example, that may have evidence of affecting your eggs. You may have a large cyst in your ovary that is endometriosis that needs addressing, and therefore you're concerned that you may reduce your future egg reserve. And so for those reasons, medical conditions also sometimes push people into considering fertility preservation. Now, an important note about endometriosis, again, I'm on the multidisciplinary endometriosis board for Ramsay Health, is that we do need a multidisciplinary approach. It is very easy in the old days for women to go in and be underdiagnosed and suffer with period pain. But then when endometriosis is finally addressed and diagnosed, they are then sent in for a laparoscopy. And remember, our eggs live in our ovaries. So if we go straight to a laparoscopy where we then cut away a cyst or remove that endometriosis, no matter how good we are with our surgery, that can damage your ovaries and it can reduce your egg reserve. And some patients then come to me ready to have a baby, even though they're in their early 30s. And we then find that they went from a normal egg reserve pre-surgery to a very low egg reserve post-surgery. And now that's in itself become a problem. So this is where it's very important to sit down with your holistic fertility specialist, gynecologist, whoever you're seeing. Don't be afraid to get another opinion. That we sometimes need to sit down and work out how old you are, what lifestyle impact your disease is having. What do we do for second and last? When do you want to have the babies? Do we put away the eggs first and then deal with the endometriosis and then come back for pregnancy? Or in what order do we approach what we do? So many things goes into planning of fertility preservation. Now, some patients need fertility preservation to go through, some patients are diagnosed with cancer and they may need egg freezing for medical reasons. So this article was a patient of ours who was diagnosed with cancer, breast cancer at the age of 27, and she had a partner. So remember, fertility preservation, as I put up in my first slide, is not just egg freezing. Egg freezing is for women who are either single or don't have a partner and want to consider their options. However, if you do have a partner and you know that it's a matter of time that you're going to have a baby, but it's later, once you've recovered from a medical condition or once you are ready to have that baby together, then your doctor may talk about embryo freezing. That is where we fertilize the egg and sperm, grow everything like you saw in the video for 5 days, and freeze it at that blastocyst stage, which is day 5 of embryo development. And at that point, we can also do genetic testing to check the chromosomes in the embryo to then make sure that it's chromosomally okay, which even then gives a higher chance of pregnancy later on. So this woman used her eggs many years later and managed to have her babies. So once those eggs are frozen, they are or embryos are frozen, they are actually held in time. So egg freezing or embryo freezing as part of reproductive planning is becoming much more common. I see patients every week who consider this as an option and factor this into part of their reproductive planning. As many as 1 in 5 would do it. So in the past, we used to find that egg freezing was experimental. And why? Because eggs are the largest water-containing cell in the body. And we used to slow freeze eggs. And therefore, when they were thawed, they used to form ice crystals. And those ice crystals would damage the spindle of the egg and therefore render the egg unusable. So we used to say that a woman even as young as 35 needed 50 eggs frozen to make a baby. And how many eggs can you get and how do you get these eggs? So I will talk a little bit more about this in the next slide, but basically, once you have seen your fertility specialist and you have decided that you're going to go ahead with the egg collection process, you will have an orientation visit with one of our nurses one-on-one to learn about the medications because they are injectables. And in order to prepare your body for egg collection, you do need an IVF cycle. Now, what's involved and why? So as I said before, ordinarily, you're born with your eggs, you're genetically programmed to bring a cohort up each month, and then your pituitary uses your AMH as negative feedback to select a usable group for the month. And that usable group, the antral follicle count that you may have all heard on ultrasound, is the number selected for that month's cohort. Ordinarily, one of them will ovulate for conception and the rest of them will retrieve or die. And the next month, we start it all again. So the IVF cycle I see to egg freeze is, to me, like a rescue mission because we're giving you injections, which are FSH that your brain uses, but at a higher dose to recruit the entire cohort to maturation rather than just the one ovulation. But the number of eggs we can collect out of a cycle is dependent on your egg reserve and your AMH. No matter what dose of medication we give you, we are governed by what the body has selected for that month. So I get many patients ask me, if I freeze my eggs, does that mean I'm using, if you get 20 eggs, you're using up 20 months of my fertility supply? The answer to that is no, because remember, we're just dealing with a cohort in that month. So it should not affect your future egg reserve. It should not affect your future fertility, and you may definitely fall pregnant on your own when the time comes. We usually suggest that you start trying with your partner. Now, the process itself, we try to make it as easy as possible for you, where once you've had the orientation, you will ring us on day 1 of your period, and you'll come into one of our clinics on day 2 to have a blood test. If your hormone levels are baseline or good, we start 1 injection a day. Most people need about 10 days of injections before they're ready for egg collection. You will come into the clinic 2 or 3 times to have a blood test and ultrasound just to check that everything is progressing well. And then once the follicles are the right size, you get a trigger injection that gets you ready for theatre. Now, once you are ready, you come into our day hospital. It's a day procedure. You get sedation. So it's not a full general anesthetic, but it's sedation so you don't feel any pain. You have a vaginal ultrasound, and those eggs are collected vaginally with a needle into the ovaries. So it's not a big operation or anything like that. Most of our patients recover within an hour, go home, and the next day they're at work. So the entire process of from beginning of medication to egg collection normally takes about 2 weeks. Now, again, the number of eggs that are required to make a baby will depend on a couple of things. One of them will depend on how many eggs we are actually going to able to collect based on your egg reserve. And the other thing that's important is the age that you freeze it at. So remember, we said the older we get, the poorer the quality of our eggs, and therefore that's why the rate of miscarriage increases and chromosomal abnormality in the embryo increases, or conditions like Down syndrome become more common because of this decline in quality. So that we usually suggest that the optimum time to freeze your eggs is between 30 and 37. Why that magic number? Because in your 20s, you may not even be considering egg freezing yet. You may meet someone at 30, start trying and start having your family and have no need for frozen eggs. Only 10 to 20% of patients at this point come back to use their eggs because, as I said, pregnancy on your own is still possible in the future. So therefore, if you come in and freeze your eggs, once you've had a bit of time to finish uni, you've started your job, you're a bit more stable, you know where your future is heading, you're more financially stable, you come in, you decide to do egg freezing, you do in your early 30s, your egg quality is still very good. And our egg quality and quantity starts to sort of slowly decline with time, but more dramatically after 38 and more so after 40. So if we are going to freeze eggs, early 30s probably the best time. But, each person has an individual situation. So you should discuss that with a fertility specialist like myself, and we can guide you through, what's required and what needs to be done. So if you freeze eggs under 37, we usually say 12 mature eggs to make a baby. And why, again, so many? Because a baby is so far, an egg is so far away from a baby. So we usually say that, for example, if you have 10 eggs frozen, only mature eggs are frozen. So we may have 15 eggs collected. Of those, 10 to 12 may be mature. Of those, we expect 85% to survive the warming process. And these days, we don't slow freeze eggs anymore. Technology has changed immensely, and we now vitrify eggs, or they're snap frozen, bang down to a very low temperature, almost like glass, so snap frozen, to keep them in that state of quality for as long as you'd like. Patients also ask me, how long do my frozen eggs last? Once they are frozen, they stay at that quality until they're ready for use, if they are maintained under stable conditions. And then when they are warmed, they behave like they would have when they were frozen, which is what's giving you the benefit of the younger egg quality and an older age when we're ready. So 85% or so of those eggs now survive the warming process because vitrification doesn't form ice crystals in those eggs like I explained before. And once they survive, they are then quite competent to fertilize and behave almost like fresh eggs. However, out of even 10 fresh eggs, we only expect to get 3 to 4 blastocysts. And out of that, only two would, 50, 60%, depending on your age, would be normal and intact to make a baby. That's why we say 10 to 12 eggs frozen to comfortably make one baby. And if we are older, chromosomal abnormality and egg quality would mean less blastocysts that are normal at the end. Therefore, more eggs frozen to begin with. I hope that makes sense. So your doctor should be able to tailor your individual number based on your situation and your age. Now, that's why I was saying if you had a partner, some people consider embryo freezing because you have already gotten the eggs, you have already put them with sperm, you have already grown them out, for those 5 days. You have already got to the point of embryos that have fertilized and are growing. And we can maybe even genetically test them there to see which one is chromosomally intact so that we know that that one has the highest chance of a baby, and therefore you have more of a tangible insurance. So it's not better or worse because egg freezing is very valid option these days and good technology, and so is embryo freezing, but it's just different because you're at a different point on that continuum. What's important to remember, however, with embryo freezing is that these embryos are connected to sperm, whether that be a known donor or a partner. And therefore, when you're ready to use these embryos in the future, you're going to have to want to use it with this partner you've chosen. And if life changes and you're not together anymore, then all that hard work may be for nothing. That's why women, still feel that if you're either uncertain with your relationship or your future, that you put some away as eggs, because then you're the boss. It's your reproductive material, and you can then choose to use your eggs when you're ready. Now, even if we have frozen our eggs at a younger age, most Australian clinics would cut off treatment at the natural age of menopause, which is 52 years of age. And that is purely because of, the fact that, first of all, most of us wouldn't want to have a baby in our 50s because of energy and time and etc. But obstetric risks increase as well to yourself and to the growth of the baby. So for many reasons, we should, even if we're delaying childbearing, we shouldn't delay it into our 50s, but it definitely gives us an option from delaying it late 20s, early 30s to late 30s, early 40s. Now, there is a cost involved, and this can be prohibitive for some people because, unfortunately, if you are doing this as a proactive young woman only to ensure your future reproductive potential, Medicare doesn't see that as a medical reason. I hope that changes in the future, and that's why you may be up for about $6,000 to $8,000 for an egg freeze cycle. However, if there is medical indication to freeze those eggs, meaning your egg reserve is lower for your age, or you've tried in the past and not fallen pregnant, or if you've been in a long-term relationship, not able to fall pregnant and have now broken up, or if you're going to have medication that's going to affect your ovaries, or you're going to have cancer treatment that is going to reduce your egg reserve, or you're going to have a large cyst in your ovary that's going to mean you're going to need surgery and that's going to affect your egg numbers, then yes, you would qualify for Medicare, and therefore you would then get a rebate for your cycle. Now, the other thing that I wanted to briefly touch on is that, first of all, obviously, egg freezing is an insurance. You are freezing mature eggs for the future. As I said, it's a safe procedure. The risks of IVF medication these days is very low because the process is tailored to you. Patients used to worry about hyperstimulation because we try to get as many eggs that your body will give us from one cycle to make it worth your while, but then you feel sick and hormonal. But these days we use agonist triggers, which have taken away the risk of hyperstimulation. You may feel a little bit uncomfortable and sore after the egg collection, but simple analgesia helps that. The risk of bleeding and infection or damage to your ovary is extremely low. It's less than 1 in 1,000. The chances of your future reproduction on your own doesn't change. So it is a very safe procedure to embark upon. However, I guess we have to remember that when we warm those eggs, so there's no test for egg quality, and we're not going to know what those eggs are going to do when you use them. That's why the earlier you freeze it, the better. However, there's no guarantee that they're going to make a normal blastocyst later when we use them. So that's one thing to take note. Second thing is to obviously, as we touched on in the previous slide, is to remember your overall general health and the risks that go with carrying a baby when you're older, and taking that into consideration when you decide when to try. And the other thing to mention briefly is that it's not just eggs, as we have said. So if a patient is prepubertal and has been diagnosed with cancer at a young age, or has been diagnosed with a genetic condition that is going to put her through premature ovarian failure or insufficiency, then there is the option of ovarian tissue freezing. That's where we take the whole ovary in a prepubertal patient and freeze it appropriately. And when the time comes to use that ovarian tissue, we can then either transplant it back into the body and give you medication to make follicles grow for egg collection, or we are now doing a lot of research of recruiting those cells and doing in vitro maturation in the lab to make usable eggs. So that's another option for fertility preservation for medical reasons. If you are postpubertal and you know, in your 20s and 30s and thinking about it to maintain your egg quality for later reproduction, then it's egg freezing. If you have a partner and want to consider freezing some as embryos because it's later down the chain and they can, you know, have more of a guarantee, then you may consider some as embryo freezing. And what's interesting, I think, is we haven't mentioned men today. Sorry, guys. You know, you seem, don't for 1 second think you're the forgotten half. So men are as important a part of the fertility journey with regards to their sperm health, nutrition, overall health, and contribution to the pregnancy and embryo health. And there are a lot of studies these days looking at advanced paternal age. So, you know, we all get told we are getting old, and as a woman, our egg quality is going to decline, and it's all about women and aging. And as I said in the beginning, that's one thing we can't change, and it's quite depressing. But you know, so far we've said that it's quite discrepant that men produce sperm all the time, and therefore they don't have the same biological clock, and it's not fair. But there are a lot of studies coming up now suggesting that environmental change over time and declining health or diets over time have seen a change and an overall decline in sperm health and function as well. And we also know now that aging in men can contribute towards problems in sperm. And interestingly, aging in men is as early as 45 years of age with problems seen in sperm health. And there are some studies that have shown that there's increased rates of bipolar and increased rates of autism in children born from older fathers. So sperm freezing may become something that's more considered as well if men want to delay childbearing. So besides social sperm freezing has always been available for pre-cancer treatment. So if men have testicular cancer, that's going to affect their testes, or if they have cancer treatment that is going to damage their sperm cells, then they should be given the option of sperm freezing beforehand. These days, technology has come so far that we can even freeze individual sperm now. So men with low sperm counts still have a chance of preservation and freezing. And I haven't touched on men with really low counts that may need a surgical procedure to collect whatever sperm they've got. And, you know, that's a topic for another day, but there's definitely lots of options for fertility preservation in men as well. Now, once you have gone through your egg freezing and you've put your eggs away, then, you know, you just come back in the future either with a partner, or if you're ready for a baby on your own, and there are options of, you know, clinic recruited sperm donors that you can look at. We run a comprehensive donor sperm program, which is consistently updated, and we follow all legislation to protect you with regards to creating a fixed number of families. Donors are registered so children can look them up at 18. There's counseling processes involved. The sperm's all been screened and tested. So, that's an option for the future. And of course, egg freezing is not for everyone. So what if you come and see your doctor, and even though you're only 37, your AMH is very low? And it looks like even with maximum medication, you're only going to respond by getting 1 or 2 good eggs at a time. So that may take you 5 or 6 IVF cycles to get to the number needed of 12 or 10 or 15 or whatever it is that has been recommended you freeze. Now, that may not be an financially or physically or emotionally viable option for some people. You may come when you're over 40, and when you're over 40, we say because of the abnormality that can collect in the spindle of the egg and therefore abnormal embryos created, you may need upwards of 40 eggs frozen to make a baby. Again, that may not be possible to collect because it'll take multiple cycles, and therefore your doctor may discuss other options. We may say that, look, egg freezing may not be the best thing because you may need 10 IVF cycles to get a number that's useful. You may do 1 or 2 to put a few eggs away just to see how you go, but it may be better for you to consider having a baby. And if you have a partner, that may mean just moderating your expectations and maybe starting to try sooner. But if you don't have a partner, there are other options. So please see a fertility specialist who can take you through those. Now, I think I have covered everything that I wanted to say today.
Excellent.
Thanks, Ella. So that's brought me to my last slide of whether you have any questions for me.
Excellent, super. We've only got 5 more minutes, and I do have a question. Yes. Do average blastocasts create healthy babies?
Yes, so a blastocyst is a day 5 embryo. So as we said, egg and sperm have fertilized and grown for 5 days. Now, the appearance of the embryo doesn't equate to the chromosomal makeup in the embryo. So the grading of an embryo, it's graded either A, B, or C for the cells that become the baby and the cells that become the placenta. And if you have an average blastocyst, I would assume you've been given a grading that's B or even a BC. And yes, we do see babies from embryos that may not look perfect. However, that would, with a caveat that they've got the normal chromosome complement.
And just one more question. This is just on the last section that you were talking about low egg reserves. Now, if you are going forward to in order to collect some eggs, but you've got a low reserve, sometimes it's not conducive to go round after round to get the 10 eggs, as you say. Is there a way to boost the eggs?
So
in order to collect?
That's a very good question. So as we were saying before, that the number that you get is governed by your AMH somewhat. So however, if you have a good egg reserve and you don't respond, then you're as well to medication. That's a separate group of patients, and they're the poor ovarian responders. So depending on what we find, if you have a low egg reserve, sometimes changing the medication or increasing the dose may or may not help. Therefore, you may still need multiple cycles. However, if you have a good egg reserve but you're not responding, then we can use androgen precursors like DHEA or testosterone to sensitize the ovaries to respond better. And then the question of can you boost your eggs, so maybe less? I'm assuming that means that you then need less eggs as a number to make a successful pregnancy. Now, that is what we were talking about in our previous session, that there's a lot you can do with your diet and your lifestyle and your supplements and antioxidants to help nourish the eggs that you've got. However, remember, you're not going to know whether they're actually going to behave better or make better embryos until you come back to use them. So that's a tricky one. However, I think we should put it all together to look at your AMH to maximize your individual response and to put yourself in the best health so that your eggs are in the best possible shape when they're taken.
Super, that's great. Thank you so much, Manny, for your really comprehensive slides, and your it's so interesting. Now, if you do want to direct some questions to Manny, or you have more questions, please head over to IVF Australia. The ladies are there, and if they need to get hold of Manny in order to ask questions. I'm sure Manny would be available.
Absolutely.
Yeah, so head across to the booth. Now, we do have over 400 people right now, so please do have a look at all of the other booths, and there is another session coming up in 15 minutes. So if you head across the agenda page, you will be able to see who is up next. Thank you again for your time. Thank you, Manny, for your presentation. That's great.
Thank you,
Take
Ella.
care.
Pleasure.
Cheers.
Take care.
Bye.
See you, everyone. Bye.